Continue with, so we have seen just now the relations above, below, front, behind, isn't it? So from this picture only you can make out this is above, this is below, this is front, and this is behind. Whatever structures you draw, you can same thing you can list out. Okay, then once you write the relations, we have bursae. Now, basically, what is bursa? Extensions of synovial membrane. Wherever there is actually more friction, there more lubrication is required. Okay, so in order to give the lubrication, we have extensions of synovial membrane. Those are called as bursae. So below the scapula bone, the biggest bursa we have, you call them as subscapular bursa. It is also called as subacromial or subdeltoid bursa. Three names are there. Subscapular, subacromial, subdeltoid, same thing. So below infraspinatus muscle, we have a bursa, infraspinatus bursa. Okay, below acromion process, subacromial. So synovial sheath, already I told you, which is extending around the long tendon of biceps, that is one of the extensions of the synovial membrane in order to give the lubrication. Okay, now once we are done with the all features of the shoulder joint, what did we study? We studied capsule, we studied bones taking part, we studied ligaments, we studied relations. Now we are doing the blood supply. So we did axillary artery as an essay question, isn't it? So if you remember axillary artery, I told you anterior, posterior, circumflex, humeral and subscapular are the branches of third part of axillary artery. So these are the blood vessels which are giving blood supply to the shoulder joint. Coming to the nerve supply, so nearby nerves we have axillary nerve, then we have suprascapular and lateral pectoral nerve. Okay, now coming to the movements, see actually this is looks very extensive, but this is your textbook picture. Vishram Singh, Chaurasia, all books gives almost same thing. So we have movements like flexion, extension, adduction, abduction, medial and lateral rotation. So you have main muscles and then we have accessory muscles. So you need not worry about accessory muscles. I want you to learn only main muscles. Okay. So, salam. See, flexion, what are the muscles? We have clavicular, head of the pectoralis major, anterior fibers of deltoid. Extension, posterior fibers of deltoid, latissimus dorsi. Like that, we have all movements better. So pictures of the movements are also shown. See this movement, which you, when you take your forearm and arm in front, you call it as flexion. When you take it behind, that is extension. Then when you bring the limb close to your body, you call it as adduction. When you take your limb away from your body, you call it as abduction. Okay, when you rotate it in this direction, that is medial rotation. When you take it away, you call it as lateral rotation. Circumduction is when you completely rotate it clockwise and anti-clockwise, you call it as circumduction. So all these movements and what are the various muscles which are bringing about this movement are listed here. You can remember two muscles, that is enough. You need not remember the whole list, not required. Okay, again this slide is also giving you the information like which muscle is bringing flexion, extension, adduction, abduction. Okay, so different pictures are kept, so many details now we don't require in a short course where we have less time and more things to cover. Okay, so now we will see certain applied aspects that is more important. So your question may be framed something like dislocation of a particular structure, like head of the humerus got dislocated from the glenoid cavity. What is that clinical condition called as? What are the structures involved? Like write the gross anatomy of that particular structure involved. Then you write the capsule, ligaments, relations, movements of that particular structure. Something like that. Direct question won't be given, but shoulder joint is an essay. So dislocation is usually, see this is the normal position of head fixing in the glenoid cavity. Suppose if the head is fixed like slipping from here, you call it as dislocation. Okay. So axillary nerve gets damaged in case of inferior dislocation. Okay, I told you axillary nerve is also supplying the shoulder joint. Okay, So we know like this is the glenoid cavity and then this is the glenoidal labrum. So sometimes there may be a crack type of tear type of lesion which is found on the interior or anterior inferior part of the glenoidal labrum, which is called as Bankert lesion. Okay. So painful arc syndrome is like due to thickening of supraspinatus muscle. See here, what happens in painful arc syndrome is person will not be able to do abduction beyond 90 degrees. Okay. So he like see pain occurs during abduction between 60 degrees to 120 degrees. So because you see there is like impingement of this tendon, supraspinatus tendon against coracoacromial arch. See, this is the supraspinatus tendon and this is the coracoacromial arch. This gets trapped when the person is going beyond 60 to 120 degrees. So that condition is called painful arc syndrome. Frozen shoulder we generally happens with age. Just now I told you shoulder cuff muscles are rotator cuff muscles, where I said we have supraspinatus, infraspinatus, teres minor, and subscapularis. So suppose if these tendons of these muscles, if they get inflamed, inflammation is tendinitis. Inflammation of the tendons of the rotator cuff muscle will lead to a condition called as frozen shoulder. Again, in frozen shoulder, what happens? The elevation of the shoulder beyond 90 degrees becomes highly impossible. Okay. Then orthodesis is like surgical fixation like this in 45 degrees of abduction and 20 degrees of flexion. So suppose if there is any shoulder joint dislocation or if there is any fracture, we generally undertake this. Arthroplasty is like shoulder joint replacement surgery, where you see if the articular capsule, if it is damaged, if it is degenerated, hyaline cartilage or articular cartilage is degenerated, which is present in the glenoid cavity and also head of the humerus, we are generally replacing with some prosthetic device. You call it as arthroplasty. Okay. Metallic prosthetic agent is generally used. Okay. So that is all about shoulder joint. Now from the question paper which is shared here, so we did two essays. One is median nerve and second essay we just finished, that is shoulder joint. So the other questions, axillary nerve we already did, right? So that's the reason. So external features and applied, sixth question, full question is not given. So I'm replacing this question, axillary nerve and sixth, both together I'm replacing it for thyroid gland. Internal capsule is also essay question. So two essays are being covered now. Okay, till I open the PowerPoint, you just try to read something. Read shoulder joint till I open my PowerPoint. Thyroid gland is the another essay, the most probable essay which we usually get. So when you just look at this picture, you are finding thyroid gland is situated in front of the trachea. Okay, you are finding these are the cartilages which we already studied, like thyroid cartilage. Right in front of the cricoid cartilage, you are finding isthmus of the thyroid. This is right lobe, this is left lobe. Connecting structure is isthmus. From the isthmus, you are finding there is one projection coming, that is called as pyramidal lobe. Okay. Now this picture is showing us again the thyroid gland. Okay, now see here, this is the histology of thyroid. This also we discussed. The lining epithelium of the thyroid gland histology is, it is lined by cuboidal epithelial cells. Okay, these are all follicular cells of the thyroid gland. This pinkish material inside we have is colloid, which is nothing but T3, T4 hormones. Between the thyroid follicles, in between, we have parafollicular cells. So parafollicular cells are concerned with the release of hormone calcitonin, isn't it? Whereas thyroid gland follicular cells are concerned with the release of T3, T4 hormones. Okay. Now, when you look at this thyroid gland, it is situated anterior and lateral to the larynx and also trachea. The right and left lobes are connected by isthmus. From the isthmus, you have an extra lobe which is called as pyramidal lobe, which may or may not be present. Okay. Then the thyroid gland, when you look into the cadaver, it is actually brownish red. Okay. Then highly vascular gland. So the level at which it is situated in the neck is, it is extending from C5, C6, C7 cervical vertebra and first thoracic vertebra, and over which tracheal rings we see, over second to fourth tracheal rings we see the location of this thyroid gland. The average width is 12 to 15 millimeter each lobe. Okay, and the average height is 5 to 6 centimeters. You can write better instead of 50 to 60 mm, which is nothing but 5 to 6 centimeters long. And then average weight is 25 to 30 grams in adults. And this thyroid gland usually increases in size during menstruation and pregnancy. Okay, so this extra lobe, which may or may not be present, is pyramidal lobe. If it is present, it often ascends from the isthmus or a part of the either lobe up to hyoid bone. Okay, then it may be attached by a fibrous or fibromuscular band, that is the levator glandulae thyroid. That means extra area what you see, the further extension from the pyramidal lobe is levator glandulae thyroid. Now see here. Now see, this is right lobe, left lobe, isthmus, and then this is pyramidal lobe. So isthmus is crossing the like second to fourth tracheal rings. Okay, and the hormones which are coming from thyroid gland are T3, T4 hormones. Okay. Now when you take the dimensions of isthmus, it is 1.25 centimeters in length and 1.25 centimeters in width. Okay. And in front of second, third, fourth tracheal rings, we have isthmus. Okay. Now, when you see the posterior aspect of thyroid gland, we have parathyroid glands. Now, see here behind we have parathyroid glands. So, these parathyroid glands are situated on the posterior aspect of thyroid gland. Okay. Now, now see here. Okay, so now after this, we will see the blood supply of thyroid gland. So the blood supply of thyroid gland, we have three set of arteries. Like we have superior, only two set of arteries we have, like superior thyroid artery and inferior thyroid artery. Okay, it's better you look at this picture, it is little better. So this is thyroid gland you are seeing, and this is the superior thyroid artery, and this is inferior thyroid artery. The superior thyroid artery, when it reaches to the apex of the lobe of the thyroid gland, whether it is right lobe or left lobe, whenever it is reaching the apex, it is dividing into anterior branch and posterior branch. You are seeing only anterior branch because it is anterior view. So the anterior branch of right superior thyroid artery and the anterior branch of left superior thyroid artery, the anastomose at the upper border of the isthmus. Posterior branch is going behind. Okay. Then, so inferior, superior thyroid artery is a branch of external carotid artery. This whole artery, whatever we are seeing, is external carotid artery. So inferior thyroid artery is actually coming from the thyrocervical trunk from behind. Okay, so subclavian arteries branch, thyrocervical trunk, it gives inferior thyroid artery. So actually the superior thyroid artery and inferior thyroid artery, they anastomose within the thyroid gland. Okay, so I'll take you to isthmus, parathyroid glands, lobes. Okay, here exclusively only thyroid arteries are shown. This is superior thyroid artery coming as a branch of external carotid, inferior thyroid artery coming as a branch of thyrocervical trunk. Okay. So now coming to the venous drainage. Actually, venous drainage itself can be a 2 marks question. Again, this picture will help you to understand. See, like a thyroid gland will have three set of veins. Like it has, this is superior thyroid vein. This point you have is middle thyroid vein, and this point we have is inferior thyroid vein. So three set of veins are three pairs of veins. Superior thyroid vein and middle thyroid vein, they drain into internal jugular vein, and inferior thyroid vein, it directly drains into brachiocephalic vein. Okay, so that is venous drainage. So once you know the arterial supply and venous drainage, so superior, middle, and inferior thyroid veins are the venous drainage. Now coming to the lymphatic, actually lymphatic drainage. So it goes to nearby lymphatic nodes which are present in the neck. That is the cervical group of lymph nodes. Okay. So this picture will not help us to understand the relations, but I'll take you to some other pictures which can help us with relations really. Okay, though theoretically it is written, but we'll see pictures. See here, thyroid gland is not seen here because all muscles are intact. So this muscle which you are seeing on the side is sternocleidomastoid. Here in the neck region, we have sternothyroid, sternohyoid, omohyoid. Okay, so geniohyoid. Okay, some certain muscles are there in the neck regions. They are actually forming anterior relations. Okay.
Ma'am, that names are required, ma'am.
Oh yeah, 100% required, better. I'll take you to a better picture that is not clear. I'll take you to one more PowerPoint where relations. Chaurasia Vishram Singh has given a simple picture, but I'll take you to that. Very, very important. Without that, relations are very important in anatomy always, better. Okay. I'm trying to open one more PowerPoint. Suppose if it is not in that PowerPoint also, then I will take you to. It is, yeah, it's here, but it's very good in fact. This is good only. Okay, I'll share this. See here. So this is our thyroid gland and few muscles are cut. So whatever muscles have been cut, now see here. So in this picture, relations are shown. The same type of picture is given in your textbook. So this is the cross section of neck. The neck has been cut in this way. That is the transverse section of the neck. So you are finding two tubes here. The anterior tube you are finding is trachea, windpipe. Behind you are finding food pipe, that is esophagus. We have trachea, we have esophagus. Surrounding trachea and esophagus, we have thyroid gland. Now you are finding certain muscles over here. No, better. These are all anterior relations. All these muscles, they are named now. So we have trapezius. Okay, we have sternocleidomastoid. We have sternohyoid. We have sternothyroid, thyrohyoid, omohyoid. All these muscles, they are clearly written in your textbooks. Open this book once. Okay. Then posteriorly, what is written is carotid sheath. So carotid sheath is actually condensation of deep fascia which is covering the great vessels of neck. So what are the great vessels the carotid sheath is covering? So it has like common carotid artery, then internal jugular vein. They are surrounded by a sheath called as carotid sheath. Okay, anterior wall of carotid sheath will have actually ansa cervicalis. Posteriorly, you will have vagus nerve, sympathetic chain and vagus nerve. This information will be given in your books better. Okay, so this is for relations which you have to learn. Relations are very important. Like here you are finding venous drainage is much clear, no? Superior thyroid vein, middle thyroid vein, both are draining into internal jugular. Inferior thyroid veins draining into brachiocephalic veins. Okay, blood supply, superior thyroid artery. Okay, and inferior thyroid artery is a branch of brachiocephalic trunk, which in turn a branch of like thyrocervical trunk, beta, which in turn is a branch of subclavian artery. Okay, So clinical way only we have many questions. So we will see. See lymphatic drainage. Lymph from the thyroid gland is draining into prelaryngeal, pretracheal and paratracheal group of lymph nodes. Finally, whole of the lymph will be going into deep cervical group of lymph nodes. Okay, that is lymphatic drainage. This thyroglossal duct is not required, but this is also embryology related. So, so thyroid gland, if it is enlarged, we studied yesterday in physiology, the enlargement of thyroid gland is goiter. It can be associated with hypothyroidism or hyperthyroidism. Okay. Generally, iodine dye is injected, and we are just trying to check with scintillations, that shining type of thing. Okay, with the help of CT scans, we do this type of techniques. Okay, that is called as scintigram. So that is all about thyroid gland, beta. So we studied more than required. Enough. Okay then. So we will move to next. What is that? Internal capsule. Okay. So till I take you to internal capsule, try to check with the thyroid gland. Okay. Is internal capsule. So I hope you are able to see the internal capsule on the screen. So where do we see this internal capsule? So first of all, we need to have some gross information. So for which I'll take you to one more PowerPoint. See here, see internal capsule is an area which is like you are finding, yeah. So this is a very good picture of the cerebrum. So where you are finding this is something like a coronal horizontal section of cerebrum. Basically, we will see gray matter outside and white matter inside. So within the white matter also we have collection of gray matter which is called as basal ganglia. So within this basal ganglia there will be a passage for the ascending and descending tracts to pass. That is actually internal capsule. Okay. So pictures. See, internal capsule is a large band of fiber situated in the inferomedial part of each cerebral hemisphere. In horizontal section of brain, it appears V-shaped with concavity directed laterally. Now see here, this is one half of the cerebral hemisphere, which is of left side. You are finding this V-shaped area is nothing but internal capsule. So on each side of the internal capsule, like superomedially, we have head of the caudate nucleus. Inferomedially, we have thalamus. Then laterally we have globus pallidus, then putamen, and then we have claustrum. So that means this particular area, what you are finding, a V-shaped area, which is passing between the caudate nucleus, lentiform nucleus, and thalamus. This V-shaped area, which is actually allowing the ascending and descending tracts to pass, is nothing but internal capsule. Now let us see the parts of internal capsule. It has anterior limb, it has genu, it has posterior limb. Then it has two more parts which are called as retrolentiform part and sublentiform part. Okay. So now internal capsule contains ascending and descending fibers going to and coming from cerebral cortex. So when we were discussing spinal cord in physiology, I have described in detail about ascending tracts and descending tracts. So both ascending and descending tracts are actually passing from internal capsule. It can be compared to a narrow gate where fibers are densely crowded. That means in that small area, we have ascending sensory tracts also, we have descending motor tracts also. Hence, any small lesion, any injury to that particular area of internal capsule can give rise to widespread derangements of the body. Okay, what are the presenting parts we have? Anterior limb, genu, posterior limb, sublentiform part and retrolentiform part. These parts I have already described. Okay, now suppose this is the spinal cord, and you can see these are, suppose if you consider these orange ones are the ascending tracts and light colored ones are descending tracts, whether the tract should go up or whether the tract should come down, they have to pass through this narrow gate. This narrow gate is nothing but internal capsule. Okay, so we have different tracts coming from different parts of the brain which you have to, like actually in chaurasia, I want this answer all of you to read from the Neuroanatomy Chaurasia book where this table is given, or you can screen record my lecture, or you can take a photograph. See, in the anterior limb, what are the descending tracts we see? Frontopontine fibers and corticopontocerebellar pathway. Ascending tracts here we see are anterior thalamic radiation, anterior and medial nuclei of thalamus. The blood supply comes from recurrent branch of anterior cerebral, direct branch from anterior cerebral. So this is, you see in the anterior limb descending and ascending tracts. In genu also we will have ascending and descending tracts. Posterior limb also similarly we have descending ascending tracts and the blood supply. Whole of this table is very important. Your 15 marks question is based on this table only, because in each part, that means in anterior limb you will be giving tracts, in genu you will be giving tracts, in posterior limb you will be giving tracts, in retrolentiform and sublentiform part also you will be giving the names of tracts and also the blood supply. Okay, this is one more picture which helps us to understand this actually internal capsule. This is anterior limb, this area is genu, this is posterior limb, this whole thing is internal capsule, which is related superomedially to caudate nucleus, inferomedially to thalamus, laterally it is related to lentiform nucleus. Okay, so that is, so the tracks are named here and the tracks are drawn here. If you find this picture complicated, you need not draw that picture. You can go with a simple picture like this. You can draw one more simple picture to impress your examiner. This one also, very rough diagram you can draw. Okay. Then coming to the blood supply of this internal capsule. See here, this is the anterior limb, this is genu, and this is posterior limb. And the anterior limb is receiving blood supply from the branch of anterior cerebral and the artery of recurrent branch of the anterior cerebral artery. Okay, then see, this is genu. Genu receives blood supply from the branch of internal carotid and branch of posterior communicating. Okay, then this is posterior limb. So posterior limb also we have so many branches. So whatever branches are named here, you practice this diagram for sure, because blood supply of internal capsule also will be specified in your question. You are supposed to specify this diagram, and in the table all the branches are given. The last part of your table gives you the names of the blood vessels. The same things are here, like they are drawn. Okay, now coming to the applied aspects of the internal capsule. So lesions of the internal capsule will, I told you it is a narrow gate, isn't it? So that means in this narrow gate we have ascending tracts also, we have descending tracts also. Suppose if one ascending tract is gone, that particular function is gone, isn't it? So lesions of internal capsule are usually vascular. Vascular in the sense, suppose if any of this blood vessel is blocked, that particular area will not receive blood supply. That is vascular damage. Okay, so it may be like involvement of medial lateral striate arteries, which are the branches of middle cerebral arteries. So suppose if these arteries are damaged, it may lead to hemiplegia, that is paralysis of the half of the body.